Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and this episode was recorded with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
All right. Well, thank you. It's a real pleasure to be here at SOMA. And over the years, you see people that you have worked with, and I've seen a lot of hugs this week, which is nice. So I am faculty at the University, just like Missy is, and I will tell you, it's always nice to have someone in another department as well who kind of sees the world and what is needed in the same way, because, I think both of our careers in going back and forth between operational medicine and academics is trying to build that bridge and help share an understanding of what the requirements are so that we can get really smart people to have the time and space to really look at problems that help people in those trenches and are at the front lines get after it in the best, most effective way possible. And so, what I'm going to talk about today, and on behalf of the center and Colonel Erickson, who's our director at the Center for Global Health Engagement, our center is one of the academic centers that's part of the Uniformed Services University. By DoD, under the university's mission, we support the commands and the services to help synchronize, educate, and help the operational forces with health engagement. So Global Health Engagement, or GHE, we're probably, because of some changes in administration and focus, that may be renamed relatively soon, as well as the DoD describing global health engagement is currently under review, and that review is actually being paused right now. So in the future, if you hear different terms like defense health engagement or expeditionary health engagement, just understand that this is probably an evolving terminology for what is described in the DoD as our ability to work with and through our partners in order to accomplish our strategic interests. And so, here's our disclaimers, and the other author of this is Dr. Chinchgada, who is one of our federal employees at the center, who she and I worked together to develop this interoperability framework, but unfortunately she was not allowed to travel. And so I don't personally have any disclosures, and these are some of the learning outcomes I had for this session. But I think if you've been here most of the day, I think actually a lot of these objectives have already been accomplished. And so, hopefully that'll allow us to go through some things and answer some questions for you about kind of what's next. And so this is what I'd like to kind of go through over the next couple minutes about thinking about the soft truths in terms of how we use them in terms of thinking about medical support during regular warfare, as well as some anecdotes where I personally have had partner forces providing care to U.S. forces in a way under crisis that actually made a difference. And then how, we can think of interoperability and crisis standards of care together as we think about risk. And at the end of the day, and it's been talked about before, our job as a medical enterprise is to give our commanders options. And some of those options can be very risky. But we have to be able to present those options to our commanders in a way that he or she can integrate that into their composite risk assessment, and that they actually have the ability to make a decision between different solutions, right? So one solution isn't a decision, right? It's either that or nothing. And so I think our job is to create that decision space and try to give a full range of opportunities for our commanders. And that's kind of what I'd like to talk about today. So, as we think about health engagement, this is kind of a framework that we developed at our center. It's based upon the Global Health Security Agenda, which is now being reconsidered by our current administration, but it's paused right now. But the thing that I like about it is the framework. So the Global Health Security Agenda is focused on infectious disease threats, but I think you can use the framework of the detect, prevent, and respond framework to think about how we can use global health engagement, not only to build capacity in our partners, but also build capacity that we can use to take care of U.S. service members and the partners that we're working with side by side so that we can do it all together. Because at the end of the day, I've heard it like every year, there's always we need to do more of this. We need to do more of that. We need to add this training. We need to focus on this, etc. But the reality is that there's only a certain amount of time in the day, and there's only a certain amount of money in the budget. And a lot of times these decisions are made based upon risk, right? And risk is a factor of both the likelihood of something happening as well as the severity of that event. And so some things may happen, but they don't happen that often, right? And like when I was at South Africa, we had a lot of discussion about this, about snake bite and antivenom, right? And yet there was a big emphasis that needed to be put on that, but we'd had no snake bites for the last 5 years, right? And so thinking about what the risk is, but then could have one the next day. So then all of a sudden it would be a different picture. And so that's a great example where I actually brought Missy into that discussion as a toxicologist, emergency medicine toxicologist, about understanding the risks and benefits of giving, non-specific, African antivenom, and within the skill set of our advanced practice operators. And so I think the role of global health engagement is to think about how we detect, prevent, and respond through a lens and framework of interoperability with our partners. And a lot of that was really laid out nicely by Mike Navala this morning as he talked about what the threats were in the Indo-CACOM AOR and how SOCPAC is thinking about and getting after kind of the threat through the lens of health engagement. And I would encourage you to think of it also as, as we partner with and we help through the by, with, and through methodology to create special operations forces or capabilities for our partners, that the soft truth applies to your partner as much as it does to us, and that they're going to need non-soft support to support and sustain their operations. And that includes medical capability, medical logistics, and everything that goes along with that. And so I think we can use that because at the end of the day, there's also risk to us. So like when I was the South Africa surgeon, what did I worry the most about? I worried about my single surgeon teams, that surgeon would get injured because there was no surgeon nearby for them. Right. And so, thinking about what individuals and what people that bring unique capability to the battlefield, if they're the casualty, who's going to be taking care of them? And that Dr. Hiles mentioned that a little bit this morning in his discussion when he was talking about his motorcycle accidents and such. And so what I want to talk about is envision and think about what I call the competition to crisis capability gap, right? Or what I'm trying to call C3G, which is basically this idea that theater is set for competition, and then something happens, a disaster, an attack, an accident, whatever. And all of a sudden a large casualty generating event happens that overwhelms your facility or your capability. What are you going to throw at that problem, right? What options do you have? And what can you do beforehand to try to put those in place, exercise them, and validate them? And this represents this idea of risk to force and risk to mission. And that, you've got to have forces in place in order to roll out the door and get the missions reached, right? And so like during a Flintlock year when we didn't get any surgery support for Flintlock, it was our German and our Canadian SRT teams that came in as part of the exercise that we then integrated that allowed us to enable the mission to continue, because without that, we would have not had any surgical capability. And as medical teams, we're always, pretty much in general, not only training, but also providing support, right? And so thinking about those risks and who you can bring into the theater and what options you potentially have. And as you go and you partner with the country, I think there's a trade-off. If you're told to, like I was told a couple of times, go do some of that good medical stuff and make the people like us, think about what the risks are that your commander's having to accept. Understand the partner that you have in their healthcare system, because what you actually want to focus on may differ based upon the context. So assuming you have a fixed amount of money, you can either build a lot of things with low capability or a few things with high capability. And that difference depends upon who you are as well as the resources you have to take care of them. So, I've seen across the theater, this real big emphasis on TC3 training, which is great. It's good. It's been effective in GWAT and with good evacuation. But I do have questions that, are kind of informed by what we're seeing in Ukraine of, is that necessarily the right time in every place based upon the context? And so, and as I said, like you can do GC3 everywhere, but if you can't get them to a surgeon ever, maybe that's the link in the chain that you need to focus on, and how we work with like the state partnership programs and other longer invested organizations to help mitigate that risk. So here are some specific examples that I've kind of lived through myself, whether it be I've heard like in the joint trauma system conference where I've heard the surgeon giving a case and talking specifically about whether or not to do a primary repair or a vascular shunt for an injury of a local national. And they made a clinical decision in the OR based upon what they knew their partner had, right? I've also heard the similar teams at different times say, we don't know what our partner has. And so it's just fascinating that if you don't know, somehow that impacts the clinical decision-making that you make for the patient in front of you, that may make a difference, right, between life or death. And so understanding what your partner can do, especially who you're going to be sending patients to. So in Somalia, we had a partner for us, so we evacuated Manda Bay that had been injured, and the Kenyan Rangers on their own called up to Nairobi, had an aircraft come down with an en-route care team and took them up to Nairobi for care. Because we had bought them aircrafts, we had done en-route care training as part of foreign military sales, and they now were able to implement and do that themselves to take care of Africans, taking care of Africans, which is the goal of what we're trying to do. During the Tongo tick in October of 2017, when we lost some of our service members in Niger after an attack by ISIS, I had no tactical evac to evacuate our casualties while tick was still going on. Because my contract CASEVAC, because it was only an advise and assist mission, would not land while there were still bullets flying. But it was the French that came and actually picked up our patients for us because we had thought through and worked out and rehearsed and planned with them about, okay, this is what we're going to do if we get in trouble, right? So the French coming and getting our guys out of harm's way. Surprisingly, even another one in the Camp Simba attack at Manda Bay, where Al-Shabaab attacked us and killed 2 contractors and one of our U.S. service members. We had several injured, and one, they were trying to, the Kenyans were trying to figure out how to evac him by boat around this little horn to get to us. And they flew him with a UH-1 that we had bought them many years ago and brought them to us. And I found out about this. I was like, whoa, did that just really happen? Right. And I had the first COVID intubated patient in Djibouti at the very beginning of March. And when I called Transcom to get him moved, Transcom said, we have no ability to move him. And we were burning through nurses at the Roll 2 in Djibouti. They were going into quarantine, and this guy was dying right in front of us, right? But it was the State Department, because they had maintained environmental control units after Ebola, and our relationship with the State Department, OpMed, that when I called them and we got them, in connected with Transcom but it was initial direct that, Will Walters said, yeah, Ramey, the answer is always yes, right? If we can do it, it's legal and it's an American, the answer is yes, right? And so having that interoperability across the interagency with our partners, both, our high-level partners as well as our host nation partners, or even maybe those of a different level, I think are very important. And so this is without interoperability, you increase the risk to force and the risk to mission, because you really don't know what you're going to face. And so why wouldn't you go in there as prepared as you can? And so this is a model that Jackie and I came up with, looking at this trade-off between quality and quantity. But the real thing I want you to kind of think about as well, and I want to highlight, is this area to the far left, and then that's red, and then kind of a pink area here, where what I'm going to call accessible crisis standards of care. Because we all know that not all of our partners practice medicine at the same level that we do. But we do know that interoperability has some specific application to planning, especially in the soft environment. Because if you're a soft unit, you have to be ready. Because when things go sideways, conventional forces or commanders call soft. And I can't do it is not an acceptable answer. And so we've got to plan ahead. We've got to look ahead. We've got to mitigate that risk. And so, these are some things that I would encourage you to kind of think about, especially enhancing the integration among general purpose forces at SOF. That means general purpose forces of your partner force as well. And then think about things like crisis standards of care and clinical practice guidelines that you're potentially going to use. Because the first thing you got to do in order to be interoperable is decide on the standard by which you're going to be interoperable, right? And that needs to happen as an agreement. And so, these are some ideas that have been percolating in my mind since this meeting last year in our medical support to irregular warfare, where we heard about what was being done by 110 and Sakir in the Ukraine before the war. And we were kind of briefed on that and what I call the medical preparation of the operational environment. And it's things like all that I've been talking about, to detect, prevent, and respond. Think about how you're going to do things, understanding the environment, using things like remote advise and assist kits to facilitate, tactical level telemedicine, coordination, et cetera. And that, just like, anything that's being done on the non-medical side, think about how that could be used to enable health operations and how you're talking to your partners. But I'm really wondering, so what are we missing, right? What assumptions are we making that are going to get us in trouble, right? This picture, I don't know if any of you guys recognize it. This is kind of from that paper that's done on survivability bias, which, where's our survivability bias now? Like, what assumptions are we making based upon the successes that we've had that we're attributing to the wrong things, right? And understanding that all of our GTPs, all of our practices, just like we heard, I think yesterday about the CPGs, that they're in the context of the GWAT fight with rapid evacuation, with almost unlimited resources, although we have little spaces where we've had prolonged field care happen even within that context. And so, making sure that we're attributing the right things to the right reasons. And so the thing that I think we're missing is expeditionary crisis standards of care. And this has kind of evolved over the last year and a half as I participated in the Irregular Warfare Center's symposium. And, it's really encouraging to me to hear, people during this meeting talk a lot about crisis standards of care. Now, I think a lot of people know about it now because of COVID, but the first time I ever heard about it was at the Transcom meeting, the GIPM-JAB, the Global Patient Movement Joint Advisory Board meeting in 2018, where one of the surgeons from Air Mobility Command gave a briefing, very brief, and General Andrus was the Transcom surgeon at the time, about crisis standard of care. And I think it was Dr. Brooks, and I talked to her about this. I'm like, this is kind of what we need at the tactical level. And so what is the crisis standards of care? Well, I think most of us know what it is based upon what COVID is, right? Where it's basically like, when we're in crisis, we don't have enough for everybody. And so how are we going to be ethical in the delivery of our care and the allocation of those scarce resources, right? And so those are some key aspects of the crisis standards of care. There's been very little published on it in the medical literature. The only thing really out there right now is this article by AJ Steinlage, who's a FERC, who's actually an intern, and I've done some other work with him. And he was here for a poster the other day, but him and his wife were both authors of this. She's a nurse, talking about, in the Role 3, about thinking about crisis standards of care in our Role 3 hospitals. And this other paper is one that I worked on with some of our UK colleagues. And with that, we kind of talked about what's called pragmatic interoperability, which is where forces that maybe you wouldn't normally use in the delivery of care in competition, but now all of a sudden in a crisis, they can deliver care that's better than nothing. And we actually delineated it as kind of 3 different levels in terms of full, moderate, and minimal. And, that really also kind of helped inform kind of my thinking about, again, it's all about risk. What risk are we going to accept? And when is something better than nothing? And if so, then maybe that should be a focus of our global health engagement, or that's where we should exercise as part of our enterprise and engagement with our partners. And so this is why I think crisis standards of care are needed. Multiple reasons and multiple levels, right? So one is, and I think crisis standards of care need to happen at the strategic, operational, and tactical level. There are certain things that need to happen in strategy policy that enable it to happen at the lower levels, and I'll kind of talk about some of that in just a second. But I think everything from like medical logistics to delivery of care to surgery to allocation of resources, et cetera, can be implemented and improved by this. And really, I think what the prolonged field care team has given us by thinking about PCC as a framework of their minimum, better, best. Thinking about what's the minimum that we would accept, what's even better, and what gets us just below, what would be the ideal. But I think a couple of key things. One is I think the psychological protection that crisis standards of care gives to our providers. And that I think it's pretty crappy when we put people in a really hard situation and then we accept them. They have to accept the risk of, do I practice outside my scope of practice, or do I let this person potentially decompensate and I get in trouble? Right. And that's come up a couple different times. I mean, really, it's kind of, it's really a tough thing that I think was highlighted during COVID when crisis standards of care and talked about liability and et cetera. But I'm most concerned about the spirit and heart of that medic and doctor who basically is faced with impossible situation, right? And there's something really good, and this is actually Jeremy Pamplin and folks at Tatrick showed that even just having telemedicine capability helped decrease that angst that you weren't doing the right thing. Having someone on the other line tell you, you're in a crappy situation, you did everything you possibly can. Right. And that psychological protection that comes from that. I think also the idea that, our partners can't necessarily sustain our level of care. So maybe we do our engagement to a crisis center level of care that they can sustain. But also as we go and we teach TC3 to all of these people and they live in a country where medics aren't allowed to start IVs, they're not allowed to give drugs. One could question the ethics of teaching somebody a skill that they could never use. But if we have a crisis standard of care that's agreed upon, they say like it would only be in these situations where they potentially have an expanded scope of practice in order to save lives, that now it makes sense to teach and train people to something that maybe is above their scope of practice in their national system, but in crisis is something that actually is something good. And so those are the kind of the things I want to think about as we think about this model, think about how we kind of develop and think about engagement going forward. And I think thinking about not only how do we help our partner, but thinking about what would it take for us to be comfortable with our partner taking care of our service member because our surgeon is down, right? Or our doctor is down, or our doctor is somewhere else, right? Having that as end state as opposed to just getting the training done. And I think, if we have that as an end state, I think that will give us kind of an end goal. I think that's something we're working towards. So just very quickly, this is kind of a framework that we've come up with, a kind of a proposed level of medical standards and crisis level. Normal is, and they're kind of framed after all of our other levels, horse health protection, and all of those, right? And so, normal would be our normal practice, right? In competition. We work with our partners under agreement. We usually exercise those. We validate them. We have our credentialing, the way we have the credentialing. MASCAL, which right now is the only standard of care that we have in our doctorate, right? It's either standard of care or MASCAL, right? And there's nothing in between that that allows us to kind of be more nuanced. And so what I would say is like one level down, or A, would be that, now we have international partners that are credentialed by their own country. Maybe we haven't exercised with them, but now they're flown in. Let's just throw them into the mix, right? And then we're going to trust that country to credential and train their providers to release a standard of care that they find acceptable for their own population. But they're still practicing within their scope of practice. The next one would be that basically it's outside their normal scope of practice, but they've actually been trained on it. Right? Like TC3, right? Like we've heard surgeon generals of other countries say, we will never let our medics give ketamine. But then you're kind of like, well, like never, like really, like you can't think of any situation where you wouldn't be okay with the medic who's been trained to do something, do it in order to, relieve pain and suffering and save a life. I think when push comes to shove, people do what they have to do based upon the situation that they're in. And so I think if we're going to put people in that situation, we need to give them that space. And then it also gives us the reason to train and engage them to that level. MASCAL is what we all know MASCAL to be. And then I'm adding on this bottom one, which is reverse triage, which is, and I can't remember which talk it was this week that talked about the line between care under fire and prolonged field care as being more blurred, right? And it's this idea where the scene is not safe. Right. And now essentially you need to not deliver care to people that are the most sick in order to get people that can get back on the line and fight. And I think having a crisis standard of care in this situation is important. because that goes against really almost every fiber in our body as clinicians to not deliver care to somebody who needs it in order to treat somebody that is maybe less injured so that the entire base doesn't fall. Okay. And I know if you do, there's some articles in the literature about reverse triage that I think it's a little controversial, but just something to think about, and something that I'm proposing that at least is there as part of the framework under Moscow. So these are the advantages. Many of them I've already talked about. And I think, what's next? We're trying to write about this, share this idea. We're definitely welcome for feedback. It sounds like there was a lot of interest in this here this week, so I'm excited to work on this. As something that Colonel Gonzalez and we talked about, and maybe something that they try to push forward in terms of policy to help enable this at the lower levels. And so hopefully we've accomplished all of those goals. And then I will just say we'll have some stuff. You can pick some stickers and some handouts from the Center for Global Health Engagement. I am the senior advisor on knowledge management. I will tell you that, like in the briefing about medical intelligence, we do have a database of capability assessments that have been done by military people that are accessible to you right now, that NCMI also has access to inform their intelligence analysis. We're looking for AARs at GHE as well as capability assessments from your organization. And so you can log on to it right now if you have a CAP card and look at it. It's by COCOM and see, for places where we'd had good engagement, like the Philippines, we have a lot of information, but others not so much. So anyway, look forward to your questions.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.